Hey, Eyes and Shine there, my friends and colleagues, and welcome to the I Give a Damn podcast, brought to you by Fluorescene Media, the same company behind Odie's on Facebook. I'm your host, Dr. Joseph Allen, and today our very special guest is Dr. Alison Bozung. In this episode, we discuss the fast-paced world of emergency eye care, sharing clinical pearls, triaging tips, and the emotional toll that can sometimes come with working and thriving in an emergency eye care center. Alison is a wealth of knowledge and really just an honor and great time talking with her. So again, without further ado, here we go with Dr. Alison Bozung. Before we dive into the episode, I do want to give a big shout out to our sponsor, MacuHealth. If you've been following my content, then you know how deeply passionate I am about ocular health, as well as improving and protecting the eyesight of our patients in the clinic. MacuHealth is known for their triple carotenoid formula, lutein, zeaxanthin, and mesozeaxanthin. And whether you're concerned about age-related macular degeneration or just want to help your patients with the nutrients they need to stay sharp, MacuHealth has you covered. We'll talk about MacuHealth again a little bit later in the episode, but otherwise, let's get going. Alison, thank you for being here.
Thank you for having me.
Can you start off just telling us why optometry and emergency care?
Great question. So optometry came about in my mind as something that was interesting in terms of kind of the eye, the actual physical nature of the eye, and then how incredible the vision is. I think you can relate to that just from an immediate past discussion we had, but it's really incredible for an organ like the eye to have so many insanely tiny parts that have to work perfectly for vision to happen. So we were doing dissections in a high school anatomy course, and we dissected an eye. I think it was a sheep eye or cow eye. I can't remember which one. And I remember just thinking it was the coolest thing I'd ever seen. And I was like pulling the vitreous out and I was like, this is a retina? Like, this is insane. How does this work? And that was literally my first introduction to like the eye, you know, and really recognizing the importance of it. And then after that, I started shadowing like a local optometrist and saw like her clinical day was like patients of all ages. She saw a teenager that vasovagaled during tonometry. And I was like, whoa, that's crazy. And then I saw like an AMD patient. She was educating them on, you know, low vision needs and things like that and monitoring their AMD progression. And she had a glaucoma patient. And I was like, this is so cool. It's so varied, the ages and disease processes that you see. And that's really what like got me sparked into optometry. And then, you know, moving forward into college, I did a little bit of, you know, working in optometry clinics. I shadowed with ophthalmologists as well to kind of decide which direction I wanted to head. And I really just felt like, you know, the optometrists that I had the chance to work with got to spend a lot of time with their patients and really got to know their patients. I could sense that there was like a relationship there that I thought that I wanted to emulate. So I just kind of went and never looked back, honestly.
That's awesome. Out of curiosity, because you said that you kind of got introduced and excited about eyes through the high school like biology
like cutting
class.
An eye apart, yeah.
Did you never see an eye doctor or optometrist before that growing up?
No.
So that's kind of different because most eye doctors I talked to, like they had an experience because they had bad eyesight and their eye doctor helped them.
Of course.
And you're like, no, look how crazy this biology is. This is
I think it's a little bit of maybe a unique entry point, but it also really helps solidify my like structure, function, correlation, and desire to really understand. And that, you know, when you're looking at an OCT, for example, and you're like, why is their vision 2400? And then you can just see the retinal layers in a certain way and you're like, well, that makes sense, you know? So I feel like that kind of learning perspective has always been there for me. And I like to sort of correlate everything together, you know? So yeah, I'm happily 2015, but I'm like slightly hyperopic. So I'm going to be presbyopic before 40. So there's some pros and some cons there.
So emergency care. How did you find that as like your niche, your specialty? Can you tell us a little bit about your journey into that?
Of course. So I, you know, really kind of leaned into the ocular disease part of my education early, as that was sort of a top interest of mine, even from when I was a first year in optometry school, even in undergrad, actually, to be fair. One of the mentors that I worked with in his clinic when I was an undergrad was really, really heavily into all this cool, you know, technology and what we can learn. So I kind of kept that part with me. And then I did my residency in ocular disease and got to see a lot of different subspecialties, kind of practice how they practice. So seeing how a retina surgeon approaches a retinal detachment, how they evaluate it, what their discussion with the patient looks like, that stuff interested me. And then I really sort of fell into the emergency eye care part. I wasn't really like aiming towards that necessarily. And I'm someone that's pretty flexible. I can be happy in a lot of different situations. So when I was at the University of Iowa, and I was interviewing there, I kind of was just like, wow, this is a really cool department. I want to be part of this place. And when they asked me what my interest was, like on my interview day, I remember sitting down with like a cornea surgeon and a glaucoma surgeon and a retina specialist and a neuro-ophthalmologist. And they were all like, oh, what's your interest? And I kind of was like, I love retina. I'm really interested in, the retinal correlation. There's so many patients that can follow with an optometrist that don't need, injections or surgery. And I could be part of the retina team. And then I met with a cornea specialist and I was like, I really love cornea. But I liked everything. Maybe not as much in the pediatric space, but I think that kind of was like, I was like, I'll go wherever you want me to go. I just want to be part of this. And it seems like a cool organization. And so from there, they were like, okay, she's flexible. So they put me half in cornea and then half in comprehensive care, which was like all of the add-ons throughout the day. So I was able to have my clinic sort of open and have spaces to put people that called in immediately or emergently, sudden vision loss, red eye pain, etc. And then I was seeing some of the inpatient consults as well that were more ambulatory that could be like brought over to the clinic. So seeing a lot of those things, so I had the ability in my schedule to open those slots up. And that's what really got me first interested in kind of that urgent care sort of thing where like half my schedule was like add-ons and you never know what you're going to see. And it was really exciting. And you get to see like, you're like the gatekeeper for all these like really unique pathologies that come in. And when someone comes in with an acute need, there's really, I think, something special about being able to like meet that person where they are and like help them in that moment, when they really need it. Which isn't to say that people don't need help in their regular exams too, but I thought that was a really cool kind of niche to fill. And then when I ended up moving back to Bascom Palmer to Miami, since my now husband was there and we decided we wanted to live in the same time zone, that was an opening that was available was the ER. And so I was like, absolutely sign me up.
So I think we all know emergency care is high stress, can sometimes be challenging and even intimidating at times because you could be dealing with something that could lead to permanent vision loss. Mm-hmm. But what is a normal day, like a Tuesday for you? What does that look like?
So it's definitely a place that could be considered, high stress in a lot of different ways. I will say that, by far and away, one of the most important things about wherever, you work or things like that is a good supportive network. And so, I feel much less stressed where I work on a Tuesday when I'm in the ED, which is funny you pick Tuesday because that's one of my days, because we have fantastic front desk staff. We have wonderful nurses that are seeing the patients first. And I'm not the only one there, right? So I have optometry residents working with me. There are ophthalmology residents working. There's an ophthalmology fellow, ophthalmology attendings, and other optometrists as well. So we have like an entire team seeing these patients, and it really feels like that. So it's never like I have to see all 12 people that are waiting right now and the 10 checking in and the 5 that are with nurses. It looks a little bit chaotic when you look at our screen, but also you're not alone, and it's exciting to be kind of part of a team. So that's like the first thing. But an average Tuesday, if I come in, my shift starts at like 8 a.m., so I'll come in, and then patients aren't scheduled, right? They just come in when they want to. So sometimes in the early morning, people are still drinking their what we call colada, which is like a really sugary espresso. That's like the fuel of Miami. So people are still kind of waking up. It's a slow start. Usually by about 11 a.m., we say the bus rolled in, and we've got 20 people checking in at the same time. So it goes through these like ebbs and flows throughout the day. And then you kind of just put your head down and you just see patients. And it's fun. A lot of times you're juggling multiple things at the same time. So I might have 2 patients getting imaging. I'm pulling another one back. I have to do a quick ultrasound over here. But we're all doing that. So it actually is less stressful and more fun at times. I think.
I think that sounds like a really cool and somewhat fun place to work at, especially for someone who's like loving disease, loving the diagnostic challenge. I think for a lot of practitioners who are working just general primary care, either in their own private clinic or at some sort of larger clinic sort of place, I think if you have scheduled exams and it's like, I've got 3 people waiting, I'm behind because there's this emergency case that's very complex and I've got to make a decision right away and I got to get imaging, but I'm trying to juggle. That's where I think a lot of doctors get elevated stress because they also know that they have these expectations overhanging their shoulders, but they need to take care of this and they want to do it right. And maybe it's an emergency case they haven't seen a ton of times, so their efficiency is not as solid. So I just imagine it would be really stressful, but it sounds like you truly enjoy and love this sort of work.
It's funny you bring that up. I have a couple days a month where I have my own clinic. So I have like my scheduled patients, right? And I actually find those days like more stressful in some ways because you have a schedule. I have patients that I see coming in, people that I know that I've seen for years now. And I know that we're going to have to, have these conversations. How's this going? We're checking up on this or following up with, how's your daughter? Is she walking yet? And I'm like, oh my gosh, I'm behind. So I totally understand, the add-on can add stress to the schedule. And I don't fortunately have to deal with the stress of a schedule very often, but I can see why that would definitely be like kind of throwing a little bit of a wrench in the day.
I imagine you see a little bit of every type of ocular emergency, but can you fill us in, give us an example of some of the types of emergencies that you either typically see, you see a lot of, or you find are really interesting? I want to take a quick break just to remind you about today's sponsor, MacuHealth. If you are listening to this, then you probably care about eye health just as much as I do. MacuHealth offers a line of incredible supplements that's formulated around published science. MacuHealth is known for featuring the 3 most important carotenoids for your macula: lutein, zeaxanthin, and mesozeaxanthin. Whether you're managing age-related macular degeneration or simply looking to offer your patients a high-quality supplement you can trust, MacuHealth has your back. Now, back to the episode.
Yeah, I mean, I think that there really is no exception to what we see because as everything comes in, right? We'll see patients a lot that have acute, PBD or retinal detachment symptoms. We see a lot of retinal detachments. We see a lot of infections, corneal ulcers, those are come in daily and a lot of times are referred in from external practices that might not have the ability to take a culture or start fortified antibiotics or things like that. A lot of mystery cases, a lot of uveitis, posterior uveitis, a lot of orbital disease as well that we see.
What kind of orbital disease?
So a lot of orbital disease. We'll see patients that come in with either a known history of thyroid orbitopathy or thyroid dysfunction that get sent in if it's getting significantly worse. And then we see a lot of patients that come in with, acute kind of inflammatory conditions like idiopathic orbital inflammation, orbital cellulitis, or the risk of that. That's always something that we're on the lookout for as well. And then unfortunately, we have seen quite a few patients that come in as referral for like proptosis of an eye for unknown duration, and they end up having a mass or some kind of lesion or things like that too.
Yeah, those are always sad, tough cases, right? With knowing how the emergency care, you get a lot of things, you see a lot of things. Is there any just generalized tips or recommendations that you would have for other doctors who do maybe more primary care? Anything major that you've learned that you think would help them? Because I know you give a lot of lectures too. Maybe questions that other doctors ask you. Is there anything that seems to be like a common theme that maybe other doctors would like to know?
Yeah, I think, a lot of it depends on sort of setting the framework for what's like the most likely diagnosis for something. And so in terms of, I teach residents, I'm the residency coordinator at our program as well. And then we have students coming through our program too. And so even within our, our own institution, we're doing a lot of educating and things. And I always try to, have the residents like piece things together, but like what's the most likely thing? And then if you have something where it's like, sudden vision loss, right, in one eye, we have the very, very fortunate ability to see inside of the eye, which is fantastic. And I think about other specialties like, like nephrology, like they can't just like look at the kidney, but we can just kind of peel back the layers and go step by step looking for what the problem is. And so if you're able to identify kind of the level of the issue, maybe it's the lens or maybe it's the retina, getting the necessary imaging is kind of the very first step. So if it's retina, OCT is obviously in a lot of offices, things like that, fundus autofluorescence. And then just kind of taking it step by step of like, what could this be? What could it not be? What do I have to rule out? So I think those are kind of the top differentials. And I always think having a wider differential at the beginning is better because you're automatically narrowing it down in your head as you evaluate the patient. But starting off more broadly so that you don't fixate yourself into one diagnosis. I see a lot of referrals for, a very specific condition. Like I get a lot of referrals for acanthamoeba keratitis, but there was no, biopsy, there was no culture, there was no confocal or anything like that. It's just like, I think this might be what it is. And they really pigeonhole themselves into that diagnosis, and then it freaks them out, it freaks the patient out. And I think a lot of times there can be some more time to do more testing and, really rule things out as we go. So taking it step by step and not getting overwhelmed, I guess. Other tips, always check color vision if it's like a weird unexplained vision loss, and have a Hertel or some kind of exophthalmometer on hand. And then one tip that I always get, especially for orbital disorders, is do the worm's eye view. So I have patients look up, like they're looking up, like almost like you're gonna look up their nose, and then look at the position of the eye, because sometimes people with proptosis have a ptosis as well. So it looks like that eye might be smaller or kind of shrunken back, but when they go like this, you can clearly tell that it's sticking out of their head. And so that really sort of puts you down a different pathway, right, of what your differentials are. And it's free and it takes 2 seconds. So worm's eye view, exophthalmometry, do not be shy about color vision. And if you work in an office where you have technicians or other staff that are seeing the patient first, be very available for them early in the exam to check pupils. Because I cannot say how many times I'm like, I wish I would have gotten to check that pupil myself. Because I feel like there has to be an APD, and sometimes your exam hinges on that one small detail, right? If everything looks perfect, it's a retrobulbar optic neuritis, they're 20/20 minus in that eye, but they're complaining of blurred vision, they're going to have an APD, but it's probably going to be subtle. So always be available. If something doesn't quite make sense, say to your staff, I'm ready to step in, just come grab me, I'll step out of my room, check it quick, and then go back. So things like that are important too.
Those are excellent tips. Really, thank you for sharing all of those things. I think I learned in school, my professors were very good at teaching me if there's something suspicious going on with the eye, double vision, any eyelid thing, think thyroid. Please double check thyroid. If something doesn't make sense, check thyroid again. At least keep that in as a differential. And I think especially with orbital conditions, that's great.
Yeah.
So what about just in general, the type of cases that you've seen? Has there ever been a memorable moment where you either were surprised or you learned something really valuable from a unique case?
Like weekly, yes.
Weekly, right.
Yeah, I think one of the things about working where I work is that I'm constantly humbled by the things that I don't know. And I think that being in a place where I am up against things that I've never seen before regularly keeps my keeps your ego in check for sure. But being able to be around people that are much smarter than I am and ask them for help when I need it is great. I can't even, so many cases that are like, wow, there's these little moments that stick with you. I think probably one of the more difficult parts about working, where I work in that setting is that we have sort of an underfunded, underserved population in Miami. We have a lot of immigrants or individuals who, aren't U.S. citizens that don't have access to healthcare that's easy, or they don't know how to get around the system very well. And so a lot of times they avoid going in for a long time, like longer than they should. And then they show up with something that's pretty advanced and hard to treat, right? I don't think that a lot of people realize that, like, we're here to help. We have social workers here. And so I always try to get people plugged in with someone that can help them get their eye drops, or like, I I probably shouldn't say this on film, but I might snag a bottle of the antibiotics I'm not supposed to give people because like, I know this guy's not going to go get his drops because he doesn't have money and he has an infection on his eye, right? So stuff like that, where you just try to help the people. I think one of like the moments, it was earlier on when I was practicing at the hospital I'm at now, and I had a patient that came in that had a history of prostate cancer that was not in remission, history of metastasis as well to other solid organs. And he came in with flashes of light, blurred vision, like blackouts of the vision in both eyes, some headaches, some double vision. Like he had like so many symptoms. I was like, there can't have all of these, but okay. And then I looked in, and then the first thing I see is like bilateral disc edema. One eye is proptotic. The motilities were restricted on both sides. And I'm like, this is like, whatever it is, it's not great. So I ended up getting neuroimaging for him because he hadn't had a brain MRI for a couple of months, and he had metastases in his brain in both orbits, and he had, the bilateral disc edema. I mean, it was just like a lot going on. And I think the hardest part about that encounter for me was the fact that I'm here educating this patient on most likely progression of their metastatic disease. And when I was talking to him and I was trying to explain it, like my Spanish is pretty good, but there is sometimes always a language barrier with like very specific things. And so I got to translate. I'm like, this is one of those times where I'm going to call somebody to help get this information clearly across. And I used the word like metastasis, in my discussion. And then he was like, what's a metastasis? And I was like, oh, it's, it's where your cancer has spread, like it has in other parts of your body. And he was like, I have cancer in other places too. Like clearly I saw through his medical notes that this has been a thing that was diagnosed in the last months for multiple visits. But it was just in that moment that I realized that not everybody's on the same page of understanding the complexity of disease or what they have going on. And I was like, I felt like an idiot trying to just explain cancer to somebody, almost like he didn't know he had it. It was crazy. Super sweet guy. And I was like tearing up in the room when I was talking with him. And then he was tearing up because I knew it was kind of catching on, like what I was saying. And I just felt completely inadequate in my education and like being able to be there for this gentleman, and he unfortunately passed away not too shortly thereafter. But those kinds of things stick with me. And I think that most of the time we get really busy with our day-to-day, getting through the clinic day or whatever it is. And I think sometimes we forget that the day that we see a patient, we might make a diagnosis that's very routine for us is like the worst day of their life, or like the worst thing that's ever happened to them, like a retinal detachment, I see like multiple a day. But for them, it's like life altering. And I think we really forget that. I've seen some other, physicians and things on social media post about that a lot. And it's really true, A regular day for you at the office could be their worst day of their life.
It's a really powerful story, and it's true. I think there's so many times, I know I've had those cases where it's just you feel like reality sink in a little bit, and you can feel the emotion shift in the room when patients start understanding it. You can feel their anxiety, their fear. And it's tough. And I think even as a professional, you have to go and digest that to some degree. Some of us, again, we can see it so much, it kind of glazes over us a little bit. But, I mean, I don't know. Do you, you don't have to answer this, but, I mean, do you ever have to talk to a therapist, counselors? Have you ever had to deal with that sort of digestion of those sort of things?
I never have. I think that I do, you have days that are tougher than others, and then patients you're going to think about, like we all do. I think fortunately for most of like what I see as an optometrist, it's not usually like life altering. It's like something we can treat and fix, and then they're back. I do feel for other professions where they're like oncologists or pediatric oncology. I'm like, I don't know how they do it. I have so much respect for people like that. But, everybody's, mental kind of gymnastics to get through whatever they saw that day is different. And so I would definitely say if someone feels like they need that support, by all means. I feel like I have a really good colleague network as well. So when I see something crazy or something that's, oh, this is really sad, I actually usually talk to my colleagues about it. And we kind of go over stuff like that sometimes, but yeah, the days can be kind of tough. But I think in the end, if they didn't see, I always think if they didn't see me, or if they didn't come to our institution, for example, maybe they wouldn't have gotten care. So seeing the positive side where someone did seek out care, and can get answers and hopefully help for whatever they have, I think is sort of the silver lining in some of those cases.
That is really good. That's really true. I know I've spoken with one of my previous patients was an oncologist, and I had questions for him about that. Like, how does he deal with that? He was a very educated doctor. He was very knowledgeable, and he was just like, we all die. It's part of life. I've accepted that when I was young. And he's like, I owe it to my patients to be cutthroat about the research, about the medications, about the side effects, about how we need to treat it, the best treatments for them. He's like, I don't have time. I don't have the luxury of feeling that emotion for my patients. I have to block that out. And it came across a bit cold, but I understood his logic and his dedication. Yeah. And so it's, I think we all have to deal with it in our own way. Yeah. But it's great that you do have such a great team at where you're working and being able to have that structure. Yeah,
that's great. I think people get, sort of, I guess, galvanized in different ways. And, I think a lot of it, it's, if you're in that field and you see a lot of loss and things like that, you do have to have sort of, you can't take everything home with you, right? That could be, I could imagine that would be really hard though. So.
Yeah, I've had moments where, you start seeing a patient who's got like sudden double vision, and you just know right away, you're like, oh, I'm gonna have to send for imaging. They probably have a mass. And it's tough. It's sad, and it hits me emotionally before they even know what's going on. I'm like, damn it.
Well, you think of all the differentials and all the possibilities. Yeah,
it's tough, and I think again, some people just don't. They've learned to manage those emotions. I'm very much an emotional person, so I feel that, But in emergency cases, sometimes I have this weird like military general hat that gets turned on, and it's like seeing a doctor at an ER they're having a heart attack, right? They just shut off. They're just like, you do this, you do this, you do this. Mm-hmm. And so sometimes I click into that and I don't feel the emotions, but I don't know. Still trying to figure out how to manage all of that.
Yeah. And I think it just comes with the territory, and it's how you're feeling that day, and different things like that too. I think that I see it as like I'm more task oriented too when I'm at work, I guess. And so I think of all the differentials, and I'm like, okay, let's rule this out. And I feel like it's like, do this. I have like my list of things to do. And so I also don't get too caught up emotionally in a lot of it, like at the beginning. And if I try not to let patients either, because they'll sometimes come in and some people have no idea what's going on at all. And some people have like the worst prognosis in their mind of like what I have. And, they'll be like, is it cancer? Like, it's a question I get a lot from like anything, like vision loss or double vision or whatever. And I'm like, let's like back ourselves off the ledge a little bit. We don't know what it is. It could be a million different things. But you're here, we're going to figure it out. And before you leave, we'll have a really good idea of what it is and what our next steps are. So I'm not even going to entertain anything right now because I don't want them freaking out for 3 hours when they wait for their MRI. It's not worth it to them to put them through that. And so I'm just like, we'll figure it out together. You're here for a reason. Glad you're here.
It could just be astigmatism. Yeah.
It's probably astigmatism. Yeah. You have 2 diopters of SIL at an oblique axis. No, I'm kidding. Which actually that comes through the ER too sometimes. I had that last week and I was like, I think you just need glasses. Like,
someone's never closed just their right eye, so they never realized how blurry their left eye is, and they're seeing double, which is really more of like a ghosting image, and then you just do a pinhole and you're like, oh, okay, refractive.
Or like the acute presbyope.
Yeah.
It's like, it's funny. I mean, you get those, I probably see like one every 2 months. That's literally like clockwork. It's like a 40 or 41-year-old that like can't blurred vision. And then they're 20/20 on the chart. And then I'm like, oh, is your blurred vision up close? And like, I can't read anything anymore. I'm like, oh, it's fine. And then we talk about it, and I'm like, let's get you in clinic for, the prescription check.
Beyond the emergency care, you've got all these clinical duties. You also kind of go beyond that. You're also giving lectures. I've seen you've written some publications. I don't know if you're involved in research at all, but you certainly are involved in educating. You mentioned you're the residency director at the clinic. How do you juggle all of that? And how do you find motivation to go beyond just clinical care?
Yeah, I think that is a really good question. I would ask you the same thing with like how you juggle everything that you do. I think probably the biggest part about juggling multiple things is that you have to like what you're juggling. Like if there's a ball that you're juggling and you don't like that ball, but you have to just keep throwing it, like it's not fun and it makes things a lot more work. And so even I go through phases where I'm like, I really don't feel like putting any lectures together. So like I didn't submit anything to this meeting or that meeting. And that's okay. Like I don't always feel like I have to do that, but when I want to do it, I know I can. And I think part of my interest in, doing some stuff outside of like my job, right? In educating my peers, so lecturing or writing, is just sharing. I feel like I'm mostly sharing opportunity. Like I have the opportunity to work somewhere really fascinating with awesome people, seeing really cool stuff and learning daily. And so if I can take some of those learning points that I got from these cases, I can actually share that with other people. And I know I was watching a video that you did with Cecilia Ketting recently, and she mentioned that a lot of like the topics that she gets for her lectures are because she didn't know something and she did a deep dive. And that's literally what a lot of us do. It's like, this was a really cool case, and I would have maybe not thought about this diagnosis right away, but because things came around, we figured out what it was. Like, I'm going to share this with people so that they don't make the same mistake that I did. And that's something that I think is really cool. And when you kind of get that like aha moment where you can actually help somebody kind of understand a process better or open a new differential for them or something, I think that's really, really beneficial. One of the best compliments I got about like a lecture that I had done was a guy that came up to me after, and he's like, you see some really cool cases. I was like, yeah, I'm like really fortunate, to work where I do. And he's like, and you're not an asshole. And I was like, thanks. And I was kind of like, what do you mean by that? But like, definitely I don't strive to be an asshole. So I was happy he said that. And he's like, what I mean by that is you're not, you'll say when you messed up on something. And he's like, it makes the rest of us feel like it's okay to like, you're not perfect. And I was like, absolutely. No one's perfect. We all mess up. Some of us are like going to admit it willingly, like myself. And then, some people maybe you won't, but we all do it, and I feel like that was a really funny comment to get. And I was like, thank you. Like, I actually thought I took that one to heart. But, in terms of writing and things like that, I do it when I have like a column for a review of optometry, which is fun. It's like urgent care. So it's really just like a cool case and like kind of exposing that case information a little bit better. But it's fun, honestly. And then when it gets to the point, because we all go through these ebbs and flows in life, right? Like I had a kid 1.5 years ago. And so sometimes, toddler life stuff gets busy, or other family things, get more busy. Then I sort of maybe put some of these side things on the background, and that's okay. You never have to like completely go in one direction and never turn back again. You can modify as you go. And I feel like that's something that I've learned just by going through life. And I've learned from other colleagues as well that are like, nothing has to be permanent. You can always change. You can always modify what you're doing, and if you don't like something, then change it. And that's okay. There's not failure in that. There's growth in that, and there's moving forward. So I think that's something that I try to keep in mind too. And also, when you like what you're doing, you're more real about it, right? So that's another thing I think you can kind of, I'm sure you get that too, right? If you weren't passionate, you would like suck at doing this, which you're really good at it. So I can tell you like it.
I definitely feel a lot of what you just said on multiple points. The juggling kind of analogy. There's multiple times in my life where I'm like, why I'm so busy, I'm getting kind of burnt out. I realize I'm juggling several things that I do not enjoy, that are not really nourishing me right now. Yeah. Or I may be interested in them, but it's just I don't have the bandwidth to handle it. Yeah. And so I have to remind myself, hey, I have the capacity to do anything I want, but not everything at the same time.
Yeah, for sure.
And so it is good to recognize, hey, you know what, I do want to do more lectures, but I got a really busy season coming up, so I'm going to dial that back a little bit, or, kind of pull things in and out, especially when you are digging into family life and maybe shifting priorities a little bit. But I think those are all really good lessons.
Yeah.
What about being in that residency director position? I know some of our listeners, maybe students and young docs, kind of thinking, hey, residency, just do you have any tips for applicants who, for whatever program they may be going to, do you have any sort of traits, qualities, things that you look for in an applicant?
Yeah, so I think a general sort of understanding for students who are thinking about going into residency programs is that personally, I don't necessarily feel like every residency is worth doing, right, for a student, right? So if this student's interested in X, Y, or Z thing, I think that they should choose a program that's going to allow them to kind of focus on that area, obviously, but also see something that they didn't get to see already. So like exploring more of something. So if someone was, in school seeing a certain type of patient population, but they really want to expand on X, Y, or Z in residency, really focus in on that. And I think that a lot of programs have so much to offer in terms of the types of patients you'll see, the types of disease conditions you'll see, the ability to work with different specialists or, ODs or MDs in different areas. And so I think that they need to be sort of picky about what they choose, because not every program is going to be a good fit for every person. And I think that knowing kind of where you want to take your career is helpful, but not the end all be all. So just because you want to work, in like a OD, MD referral practice, it doesn't mean you have to do your residency in one necessarily. Or like, I always kind of thought like, oh, you should do your residency around where you want to practice because you get to network locally and things like that. That's not necessarily something that's true, because now we network so much broader regardless because of all these different connections and meetings. And then another thing I'd always would say too is that when you're going to interview, at these different programs, I feel like the interview kind of goes both ways. And one thing that I actually appreciate about some, especially students I've talked to over the last week, even one today at Academy, and then one like last Wednesday, like 2 days ago before I left, they had really good questions for me. And I was excited that they had like done their research and they had good questions about the program, because I'm like, you're interviewing the program as much as they're interviewing you, because ultimately a good fit goes both ways. It's not just like, oh, you apply to the program and like cross your fingers you get in. It's like, you want to make sure that's a good fit for you too. Like, does the group setting or the setting you're in, does it match where you think you're going to learn best? If you are someone that has like this need for like a one-on-one mentorship, where you're always with that one person in clinic or one or two people, and those are your people, maybe don't go to a huge institution where you're going to be with a bunch of different types of varying opinions and different specialties. So everybody learns in a very different way. Our program is very collaborative between ophthalmology and optometry. You work with both ophthalmologists and optometrists. And then you also, staff fourth-year externs in an optometry resident clinic. And so we try to keep a lot of, this kind of, I call it like a ladder of learning, where you're learning from above, from your attendings, and then you're also teaching to students as well who are where you just were. So you really know where they're coming from. And I think that for me, I think it's a great learning experience, but I don't know that every person wants to do that kind of learning, right? So again, every program is very different, and they all have pros and cons. So just making sure you can like see yourself there, that's a good fit.
I think that's a great answer and kind of insight from somebody who myself have done a residency, and you want to be happy. You're investing a lot of time, and it's going to be a tough challenge, especially for the first few months, like right out of school, like kind of learning what you don't really know. And you want to be excited to go, and that you're investing your time wisely, rather than finding out, oh, geez, I'm glad I got in here, but now this is not what I thought it was going to be. This is not where I want to be. Yeah. Then I've only known one doctor who started a residency and then pulled out after like a few months.
But at least, I mean, I think that's like, it's not a failure. It's like they realized it wasn't the move for them. And, you know, again, that's a ball they were juggling that they didn't want to juggle at that time, right? It is good. I mean, I'm super supportive of residencies. Like, obviously, I'm a big advocate for that because I think it adds so much to your education. And I can't imagine practicing without having had done one. But it's not for everybody, you know? If you're really not passionate about that, or you know, feel really confident going into whatever you're going to go into, then maybe you don't need to do one. You know, maybe that's not like the path for you, and that's okay. People have different paths.
To kind of close out the interview here for the I Give a Damn podcast, right? We try to have people on that clearly give a damn about what they do. With the whole field of optometry, I like to think, if you were suddenly elected, I know you've seen the episodes before, but if you were suddenly elected tomorrow as the kind of Surgeon General of optometry, and you could take the next year to focus your efforts to be like, I want to see this change in optometry, I want to see this change in healthcare, or you could snap your fingers and make a wish for the profession in some way, what do you think you'd want to focus on?
Wow, that's like do you ask that question to everybody?
I try to.
I must have missed
time
that.
Permitting. But
I must have missed that in the ones that I watched, or I didn't watch till the end. That's a really tough question. I think there's a lot of things that I would change. I wish that, you know, in terms of optometric education, that there was just more patient encounters in general. Like, I think seeing more is better. So that's something I you know, support, like seeing a lot of repetition and things like that. And a lot of clinics do a great job, and a lot of schools do a great job with that. But I know some schools maybe struggle for some of the numbers. I think also being, you know, I think our profession sometimes can be a little bit difficult to navigate because every state is so different in what they can do. So I would love if at some point, you know, the states were a little bit more equal in the different things that they can do, and our education really pushed for that. So maybe in the future, does everybody have to do a residency to get to that, you know, kind of a more equal or level playing ground or something? I'm not really sure what that would entail. But I know that some states have more restrictive practicing laws, and that actually deters, you know, good ODs that want to practice full scope from going to certain places that might need the help. So I think that's maybe a detriment to our profession, is having sort of the unequal nature of our profession. What else? I feel like there's a lot of things. I don't know. I just feel like, you know, us being more, you know, supportive of each other in general. I love different, you know, social media groups like the ODs on Facebook and like ODs on Optomap and things like that, because people can just share honest questions. And I always love to see like kind responses where people are like helpful. It's not always what happens, obviously, but when people kind of like help each other out, and, you know, it's like got this weird picture, like, someone, what do you think? You know, I love those discussions that can happen more honestly. So I would love to see more of that too, kind of more collaborative efforts, and then, you know, inter-optometry referrals as well. So if you know an optometrist that's really skilled in management of, you know, ocular surface disease, and you have a patient, send them to that OD, you know, and we can really support each other in that way. And also we still, you know I'm very good friends with a lot of ophthalmologists. I'm married to an ophthalmologist. And so I think that we can also support each other's professions. You know, ultimately a lot of ophthalmologists want to do surgery, right? And we can manage so much of the medical stuff that I think we should handle whatever we can, you know, and refer the surgical patients when they need things like that or more advanced care if we can't provide it. But until it gets to that point, I would love to see ODs really stepping up and, you know, doing the most we can for the most patients, right? So another thing that I would like to see.
Well, I know we asked for one, but very well said. That's when
I don't have like an answer prepared. I like just kind of ramble like 18 things.
It was very good though. I think it gives an overall snapshot of similar answers we've heard from some other ODs on the podcast. So.
Yeah.
Alison, thank you so much for coming on. This was very insightful. Really just happy that we have you in our profession and as a leader, and you're sharing so much knowledge and experience with so many of us. So again, thank you.
Thanks for having me. It's been fun.
So that was our episode. Thank you guys so much for tuning in. Thank you so much for just listening to as many of these episodes as we've been able to produce. I do encourage you, if you have any comments, inspiration, any like ahas and takeaways from this episode or anything throughout this series, please join us over on Odie's on Facebook and continuing the conversation over there. Again, Dr. Allen here from the I Give a Damn podcast. Keep an eye on it, and I hope you have a great day.